Good afternoon, everybody. It's nice to see some of you virtually, and I apologize that I can't be there with you in person. I'm here on service here at Fleury Children's Hospital in Chicago. My name again is Teresa Venti. I am an assistant professor of pediatrics here at the Children's Hospital, but I have a background that's pretty varied. I trained in pediatrics, adult psychiatry, child psychiatry, and eventually palliative medicine. And I'm here to talk to you today about the roles of palliative care in leukodystrophy, and I'm really grateful for this opportunity. I have no conflicts of interest or any financial disclosures to report. And we'll get started with just talking about some of today's objectives and things that I'm hopeful this talk will be able to provide to you. First, I'm hoping that we can think and describe the roles of palliative care providers for patients with serious illness, identify providers associated with palliative care and the variety of settings in which they work, recognize how expert communication can help to identify goals and support decision-making, and develop an awareness of resources that are related to symptom management, longitudinal support, and decision-making for families. Just a brief outline of how we're going to cover some of those objectives. So I'm going to start by introducing and defining palliative care. Some of you may be familiar with this specialty of medicine, and others this may be a new field that you're learning about. I'm also going to talk a little bit about what makes good communication and how to kind of broaden the conversation within the medical context. I will speak about establishing a baseline and what it means to, quote, define quality of life, which may be a term that many of you have heard in the context of, caring for individuals. We'll think a little bit about symptom management considerations. I will spend some time talking about planning for the future and outlining a framework regarding decision-making. I will also speak to longitudinal family support, how to support caregivers and other family members, and then provide some resources that hopefully you will all find helpful and informative beyond just this talk. So I thought one of the best ways to start would be to talk a little bit about what palliative care is not. Oftentimes I find that many families have some misconceptions about palliative care, either from things that they have experienced with other family members, things that they've heard, whether it be through social media or, other contacts, to really kind of give you a scope of what palliative care is not so that we can really define what palliative care is. When we review these misconceptions, it may be that you identify with some of these things, and I'm hoping that you'll take pause and think about, what this has maybe meant in the journey of whether you would have involved palliative care previously in care of a loved one. So we'll start at the top. A common misconception is that palliative care is only for people at end of life, and that palliative care is essentially equivalent to hospice care. I'll talk a little bit about the differences between palliative care and hospice later in this talk, but I want to provide a framework that palliative care is for patients across the lifespan and throughout their serious illness journey, and certainly should not be reserved for just end-of-life scenarios. And I'll give a little bit more detail and context around that. This is similar to another set of misconceptions in which people fear that when they have a family member enrolled in palliative care, that those patients will then no longer be able to receive other types of treatment, and that they would lose access to other physicians or their main providers, or that they may have to spend all of their time in a hospital inpatient. And we'll talk about each of these things kind of individually and why that is not the case, and what things palliative care can actually do to support a patient where they are, in a variety of different settings, not just within the hospital. And Also to speak about how we collaborate with primary medical teams and other providers to ensure that care is really team-based, and palliative care is an extra layer of support, but isn't taking over care. There's also a misconception that palliative care only provides pain medication, and that when patients receive palliative care, it means they will die sooner. And that is certainly not the case. Palliative care is here to address symptoms, and certainly pain can be a component of that. But the scope is far more broad than just thinking about distributing pain medicine. And certainly we know from studies that patients who are enrolled in palliative care actually live longer with support from a palliative care team than patients who do not. And so there is no reason to believe that any patient who's enrolled in palliative care would die sooner. So now that we've talked a little bit about what palliative care is not, let's focus on trying to define what palliative care is and explore what it is that palliative care can do for patients and families. What are the tangible things that palliative care can provide? So palliative care is an approach to medicine that really tries to bring quality of life for a patient and their family to the forefront of their medical care. It's provided in the setting of a complex, life-threatening, or potentially life-limiting diagnosis. And I want to highlight the word potential, right? Because palliative care does not mean terminal. Palliative care does not mean terminal. And so when we look at the broad spectrum of patients who can potentially benefit from palliative care, it really is more related to the level of complexity around supporting quality of life and bringing comfort and support to a family. And we'll talk more in detail about the resources that we can provide in that way. Palliative care can be incorporated at any point in a patient's illness trajectory. And in fact, most cases where there's the greatest benefit from palliative care involvement is gleaned when there's early involvement of palliative care in a patient's medical care. And this includes even at the time of diagnosis or shortly after diagnosis of a complex medical illness. There has been efforts across the board within pediatrics and adult medicine to try and emphasize the importance of earlier involvement in palliative care. And this is a movement within the medical community. And I think it's something that has really gained traction, particularly within the world of pediatrics. Medical providers who are palliative care specialists are trained consultants who work with primary providers and other disease specialists. So we work with neurologists, we work with immunologists, we work with primary care physicians, and we create a specialized treatment plan. The work is collaborative, and as I mentioned before, under the slide that mentioned misconceptions, palliative care never replaces a primary provider. You never lose your primary care team by adding palliative care to your consulting physician kind of lineup. You know, oftentimes in patients with complex illness, patients with leukodystrophy, you're seeing so many providers across the board. And so, you know, palliative care, it can be another group, another consultant who can be additive and beneficial to care. I want to come back to this point again. Palliative and supportive care does not speed up the process of dying for patients. Over and over again, there has been literature to support this being the case, that when patients' symptoms are well managed, when they are more comfortable, when families feel well supported, when there's less existential distress, that patient's quality of life is improved, and that often will equate to an actual extension of lifespan, not a shortening. And so this is, I think, really important information for families to know and be aware of. I also want to emphasize this point. Palliative care can typically be provided wherever a patient lives. It does not require a patient to spend all of their time in hospital. And we will talk about more specific settings in additional slides. But I want to make sure that I really do emphasize that this isn't committing a patient to having to remain in hospital just by consulting the palliative care team. And palliative care can exist in conjunction with other treatments. Having palliative care as a part of a care team does not exclude the ability to participate in clinical trials or other disease-directed therapies, or a continuation of treatments aimed at life-prolonging measures. Palliative care is in addition, in most cases, to those things, and so isn't a replacement for. And really, the overall and ultimate objective is to improve quality of life for a patient and their family. So while this oftentimes includes addressing symptoms such as pain, where pain medication may be appropriate, there's so many additional resources and things that the palliative care providers can offer in relation to support, not just for the patient, but for the family. And we'll talk in a little more detail about what some of those are. So when we look at the role of palliative care, again, I want to emphasize that it's provided in addition to treatments that are intended to be curative or life-prolonging. And involvement of palliative care is not based on prognosis. So as I mentioned, it is typically in the context of a complex or serious illness, but does not equate to what historically people have thought of as a terminal diagnosis. That is not a condition for palliative care involvement. Palliative care really focuses on the preference of caregiver goals. And so we'll talk about how to elicit those preferences in more detail and what the palliative care team does to understand what's important to a family, how we can be most helpful to a family, and try to align with family members in order to make the best possible medical decisions that reflect your values. I also want to highlight that palliative care is really an interdisciplinary practice. And so there are consequences other than just symptoms in the context of complex medical illness. This can include, functional impairments, psychological and spiritual distress. And so all of these things, palliative care can help to address with the interdisciplinary nature of our team. And we'll talk about the variety of providers who can be involved in providing those layers of support. As I mentioned, palliative care does not just occur in a hospital. And so palliative care can really be found within hospital settings at most community hospitals, academic medical centers. Some of you may have met a palliative care team in the context of a hospital stay. But palliative care is also readily available in most communities and can often see, and most commonly see, patients in their own homes. Some palliative care programs may also offer outpatient clinics or even have a freestanding inpatient respite unit that can be utilized by family members for their loved one when there may be a need for a slightly more acute period of symptom management and care that may not require a hospitalization, or even just to alleviate some of the caregiver burden that can be associated with complex illness. So these are all potential settings in which palliative care may be able to take care of a patient. And so when I talk about the interdisciplinary practice of palliative care, it's important for me to identify who those providers are. And so a typical palliative care team will include physicians, advanced practice nurses, RNs or bedside nurses, who can also be nurse coordinators, social workers, psychologists, and chaplains. Depending on the size of a program, they may also offer additional providers. This can include things like physical therapy, art and music therapists, even child life therapists who can help, care for younger patients or even care for children of older patients or sibling support in a variety of different ways. Some programs even include things like integrative medicine, such as massage therapy, that can be offered in a patient's home and can provide another level of symptom relief that isn't just related to pharmacology. So I've spoken in a lot of kind of vague and rather overarching terms around how palliative care can be supportive. But what skills can a palliative care provider tangibly offer your family? Well, palliative care specialists have advanced training in communication, and they use that training to work with your family to define treatment goals and make decisions about complex medical treatments and therapies. There may be a series of interventions, therapies, or other things that are offered or recommended. And sometimes the impact of those things can be an important thing to discuss with a neutral third party. And so the palliative care team can serve as a sounding board to really have some of those discussions and ensure that your questions have been answered, that you have all of the information that you need to make the medical decisions that you have to make in the context of your family and care of your loved one. Another area of expertise for palliative care specialists is symptom management, particularly symptoms that can impact quality of life. So as I mentioned before, this can be pain and non-pain symptoms. This can be related to things like emotional or psychosocial distress. I mentioned that chaplains are a part of the interdisciplinary team for palliative care. And so spiritual distress is something that is also covered by palliative care specialists. Thinking about things like anticipatory grief. And this doesn't have to be necessarily in the context of loss of life, but thinking about all of the things we grieve. So it may be a change in functional status. It may be missing out on something that's important to a family member because they were in hospital undergoing treatment or not feeling well. So there can be a lot of complex and anticipatory grief wrapped up in a serious medical illness, and palliative care can help to support families and patients through that. We also work to address family and provider distress, recognizing that certainly when there are a lot of complexities to medical illness, when you're forced with making multiple difficult decisions, there can be a sense of decision fatigue at points. There can be concern that perhaps your overall goals have shifted or changed and the medical team and yourself are no longer aligned in the way that you once were. And so palliative care can help to be negotiators and ensure that you are feeling as though you are at the forefront of the medical decision-making and you have a shared decision-making model with your medical team. And then one final area that palliative care does support is end-of-life care. This is a small piece of what palliative care providers do. We certainly do play a role in caring for actively dying patients. We do play a role in thinking about sometimes the need to consider withdrawal of life-sustaining therapies. We do think about referral to hospice and coordination, and we do provide bereavement support. But as you can see, it's taken me quite a long time within this discussion already to even get to end-of-life care. And so I want to really emphasize the focus that that's a small piece of our practice of palliative medicine. I've spoken a little bit about communication and how palliative care providers are experts in communication. And I want to focus a moment more on the communication skills that palliative specialists can offer. So palliative care providers use a framework of shared decision-making, and you heard me use the phrase shared decision-making moments ago. And we place a priority on the caregiver's role in medical decision-making and acknowledge that this will be influenced by things like racial, ethnic, religious, or other cultural beliefs that influence family values. And those may differ from values on the patient and family medical team, right? And so it's important that we have a sense and an understanding of what's important to each family and understand who you are as a family as we try and navigate decision-making. Shared decision-making also focuses on transparency of medical information. And so palliative care specialists, as I mentioned, help to really ensure that you're getting all of the information that you need that's important to you, especially as you formulate questions about, what certain types of medical therapies or care may provide, or what side effects or what potential burdens there may be associated with treatment options, so that you can consider how to make the best decisions for your family. I will also say that palliative care decision-making is collaborative. And so while the focus is on the patient and the family, all of the stakeholders really come together, and palliative care can help negotiate things like family meetings to ensure that if you need presence from all of the providers who are stakeholders in your loved one's care, that they're an audience for you to be able to answer the questions that you need answers to kind of formulate a treatment plan. At the basis of all decision making is an understanding of the goals that are important to you and your family. So palliative care providers really work to help establish goals at a variety of points within a patient's medical journey, recognizing that goals may shift over time, but trying to figure out what aligns most with family preference and values. As I mentioned, this isn't a one-time discussion, right? So oftentimes there's need for reflection and processing, as things change, either in response to, effective treatment or, challenges and finding what the next perhaps treatment may be. Health status and level of function may shift. And so that may mean that a new conversation around goals or what's most important may be helpful. Really, the role for palliative care providers is to be an advocate for you and your goals, and to ensure that the rest of the medical team is listening to what's most important for you in terms of your values as you think about, what makes the most sense for therapies or what recommendations that you are going to go with from primary providers. And so on the next few slides, I want to focus in a little bit more detail about how palliative care can provide meaningful support for patients with a diagnosis of leukodystrophy across a lifespan as it relates to symptom management, family support, and planning for the future. So shifting away from communication into symptom management, it's a secret to all of you about the spectrum of symptom burden that can occur with a diagnosis of leukodystrophy. Palliative care providers work in collaboration, as I mentioned, with other primary providers and subspecialists within neurology, rehab medicine, immunology, other specialists who help to address symptom burden. Palliative care providers are experts in pain management, and that can be related to discomfort associated with things like feeding intolerance or visceral hyperalgesia, which can be difficult to diagnose and treat. Palliative care providers also provide additional guidance for symptoms that could be a side effect of therapies or other treatments. So this can include things like nausea and vomiting, constipation, increased secretion burden. And we think about how to treat these symptoms in the context of providing a level of function that's important for patients, but also thinking about how to optimize symptom management without causing additional side effects. It's not physical symptoms alone that palliative care specialists address. And I mentioned that there were some other areas related to the symptom burden within complex and serious illness that palliative care specialists can be helpful with. And so this can think about symptom burden as a impact on function acutely, but also thinking about function over time, thinking about anticipatory guidance and about how there may need to be review of adaptive technologies or other things to help ensure that a level of function that's important can be maintained for as long as possible in the context of a leukodystrophy diagnosis. Palliative care providers also have to provide expertise in managing caregiver distress, as I mentioned before, and thinking about ways to augment resiliency for family members. So we do spend a lot of time focused on how caregivers can care for themselves, making sure that you have an outlet for coping and support, and that we help to highlight areas of strength to build resiliency, recognizing that certainly distress and burnout can be a common thing that caregivers face when they're trying to care for a loved one with serious illness. In addition to symptom management, palliative care specialists also provide longitudinal support. So in particular, when a relationship with palliative care is established early in a patient's diagnosis, one of the benefits that palliative care specialists can provide is this level of longitudinal support. And this can include continuity across care settings. So recognizing that a patient with a diagnosis of leukodystrophy may have planned or unplanned hospitalizations, so time spent inpatient. There are frequent follow-up clinic visits in a variety of outpatient clinics, and potentially even the need for collaboration or coordination of care at home, so in the context of potential community palliative care supports. And so palliative care providers can see patients in each of these settings. They can follow you inpatient, outpatient, and at home to provide continuity kind of across the medical journey. We know that patients with leukodystrophy will often have multiple subspecialty providers involved in their care, and so coordination across those subspecialists can be difficult at times and sometimes burdensome. Nurse coordinators are a gem, and certainly palliative care teams with nurse coordinators can be a huge benefit to families to help ensure that some of that burden is taken away, and thinking about how to make sure communication is happening seamlessly across the multiple providers who may be involved in making recommendations or providing guidance. Families also benefit from longitudinal support for siblings and other family members, especially at younger ages. Child life therapists who are associated with palliative care can provide guidance in age-appropriate language through educational resources and answer questions that siblings or younger family members may be asking about either changes they're seeing, or if a loved one is away from the home and in the hospital for a period of time, or if there are changes in functional status, how to talk about those things in an age-appropriate, developmentally appropriate language. And by following a family longitudinally, palliative care can also provide support if and when a patient dies from their underlying disease. So I mentioned that end-of-life care is a small part of what we do, but within that scope, we do work through grief and bereavement, which we recognize is very complex for families, and a relationship with palliative care can help with support through that process, especially if palliative care has been involved longitudinally, from earlier around the time of diagnosis. Ideally, you have a relationship with that team, hopefully one of trust and support, and that can be really meaningful for families to have a team that is prepared and educated to be able to provide some bereavement and grief services for the family. As families are faced with planning for the future in the setting of a leukodystrophy diagnosis, there's many things that you're considering regarding the potential progression of symptom burden or loss of function. And navigating what the future might look like or what resources or supports that you might need is certainly also a challenge. Palliative care specialists can help in exploring considerations for the future and thinking about changes in function over time. Oftentimes in palliative care, we talk openly about our shared hope for the future, our shared hope for the success of therapies and trials and interventions, while also preparing for potential or likely challenges that could arise. For families with a leukodystrophy diagnosis, this may involve thinking about difficulty with eating and swallowing. It may be thinking about the potential needs for respiratory support, or acquiring a variety of different levels of medical technology to assist with neurologic changes or motor dysfunction that can occur over time or with disease progression. It may also involve navigating frequent illness, recurrent hospitalizations or unexpected hospitalizations, and balancing a desire to manage comfort at home versus spending time in hospital. And thinking about what happens, when there may be functional changes or recurrent hospitalizations, and there may be a new baseline to figure out and navigate, at least for a time being. And when we are navigating the future what ifs, this also likely means time spent in serious consideration of decisions for a variety of proposed treatments and interventions. So this might include therapies aimed at halting disease progression, things like stem cell transplant or experimental drug trials. It may include weighing the potential benefits versus perhaps unknown risks, and that can be a challenge for families. And palliative care specialists can be a resource to help process medical information and a sounding board as you weigh those decisions. And thinking about, what we've learned in regard to your values and what's important to you, and trying to ensure that we're aligning recommendations from the medical team to recognize those values. Additional considerations might be surgical interventions to address function, or in some cases, prolong life. For most families, there may be some decisions or recommendations that seem more straightforward, seem like a natural choice, and it may make sense to pursue, while there are seemingly maybe others that are more difficult to make a decision about. Or maybe the decision seemed clear, but due to other changes, that may make things more difficult as well. Palliative care specialists can provide a framework for shared decision making when there is a complex medical decision that families are faced with. I want to spend a few moments and talk about some palliative care resources for families that are online and free and easily accessible and can be helpful when thinking about the future. I'm going to spend a bit of time talking about something called the 5 Wishes and something called the Courageous Parents Network, and perhaps these are already familiar to some of you. So the Courageous Parents Network is a non-for-profit website that provides resources through written testimony and videos to help assist families when they're making complex medical decisions around interventions like tracheostomy or clinical trials. There are a variety of diagnoses listed on the Courageous Parents Network, and you can navigate through them. With disease-specific resources, they do have some dedicated to leukodystrophy. And these resources are all from a patient and family perspective. So this is not medical provider based. There's not testimony from medical providers. It's really focused on the experience from patients and families, and trying to help people know the stories that families have been through as they've navigated diagnosis and decision making for their children. Another resource that's available online and can be supportive to families with a complex disease for patients of all ages are advanced care planning tools designed by the 5 Wishes organization. So the My Wishes guide is designed for school-age children to start conversations about things they would want to share with their doctors and nurses who are caring for them, and what helps them to stay comfortable. There's another guide that is designed for adolescents and young adults to share who they would want to make decisions with them or for them if they were not able to participate in decision making, and what it is that they value the most regarding their medical care. There's also a guide that's designed for adults, and this is considered to be an official legal advanced care planning tool. So it can serve as a living will where people can name a healthcare proxy. It's also recommended that adult patients consider having a power of attorney for healthcare that can specify instructions for their healthcare proxy in the event that they are unable to make their own medical decisions about interventions or treatments or life-sustaining measures. And this varies from state to state. But most states have their resources and their guides available online to be able to fill them out. And then, they can be legally binding. And Before I end this talk and open things up to questions, I do want to say a few words about hospice and how hospice is distinguished from palliative care, which I said I would get to. So hospice is an insurance benefit that provides a specific form of palliative care delivered by a licensed hospice agency. Some hospice agencies also offer community palliative care support, so sometimes they are combined into one organization. Hospice services are under federal regulation, and so the medical services that they provide are mandated by the federal government. So this means that all hospice organizations must have care provided by hospice physicians, hospice nurses, have psychosocial support with social workers, and spiritual care providers. They also supply medications and medical equipment. So for a patient who's enrolled in hospice, all of their medication related to their primary disease are covered by the hospice organization regarding things like symptom management. In order to enroll in hospice services, a patient must have a life expectancy of 6 months or less if a disease follows its expected course. This does not mean that after 6 months a patient is discharged from hospice. It may mean that a patient needs to just recertify with approval from a physician that a patient is still medically eligible to receive those services. We have many pediatric patients who are enrolled in hospice for years, because it can be difficult to understand exactly, even prognostically, how certain complex illnesses will progress. And in the context of new therapies coming on board, it can be even more difficult and challenging to know exactly what to expect. It's also important to know that within the context of pediatrics, the Affordable Care Act passed well over a decade ago, has mandated that for pediatric patients who are covered under Medicaid, concurrent care must be provided. So this means that children are able to enroll in hospice and receive hospice level supports while also receiving disease-directed therapy for their illness. So this allows them to continue to participate in things like clinical trials, undergo things like stem cell transplant, and have access to disease-directed therapies. Some private insurance companies do offer this benefit to pediatric patients, but because they are not legally mandated to do so, it can be difficult to get approval. I will mention that hospice providers are experts in end-of-life care along with palliative care physicians. And for many pediatric patients, hospice care does occur at home. So if a patient is enrolled in pediatric level hospice care, many of those services will be provided at a patient's home. Whereas for adult patients, there's a bit more of a choice, and sometimes individuals will seek to be admitted to an inpatient hospice unit for care at end of life, which is a bit more of a personalized setting than just a hospital room, but is not the patient's home. I did mention that palliative care plays a role in end-of-life care, and so it's important to acknowledge that as it's a vital support to families, but again, such a small part of the big scope of work that we do, and that it's just a small piece of the resources that we can offer as outlined by the talk. So again, I thank you for your time this afternoon, this evening, and I know it's already been a long day of the conference, so thank you so much for tuning in. I'm happy to take questions if people have questions in the audience now, or if you would like to contact me, you can certainly reach out to my email above. I'd be happy to answer questions individually, or if you have questions about resources, provide some additional guidance in that regard. So, thank you so much again, and we have a few moments. Be happy to answer questions if folks have any. All right. Well, I don't see any questions in the chat. I don't know if anyone there in person has a question to ask.
Question. Okay, start with the first one.
We ask for services like music therapy and massage therapy for palliative care.
So the question is, how often do you ask for services such as music therapy and massage therapy for palliative care? If the program is large enough that they offer some of these additional therapies, then we certainly ask every time a patient is enrolled to have access to these benefits. So I would say, for the local pediatric palliative care organization that we work with here in the community just outside of Chicago, we ask for music therapy and massage therapy to be included for all of the patients who are enrolled in palliative care. We do recognize that not every team may be large enough to have frequent access to these programs, or some may be small such that they may not have these services readily available. But certainly Child Life is typically available for their family members. But even the adult programs, many that are large enough do have access to these services. And so we consider it just part of the package. And so every patient, who's interested should be able to have access. So another question is, when asking for supplies for respiratory support, do you offer suction catheters? The question depends. The answer really depends on whether or not the patient's enrolled in palliative care versus hospice level care. So a patient who's enrolled in hospice level care, typically all of the durable medical equipment usually is billed through insurance. While palliative care can help to ensure that we're thinking about all the supplies that you need and make sure that there's coordination around ordering supplies, palliative care teams themselves do not provide the durable medical equipment. For patients who are enrolled in hospice, who do have respiratory support and have a need for suction catheters for symptom management for secretion and clearance, then absolutely that equipment should be billed through the hospice medical supply company and would be directly available to the patient at home. The question is, does hospice also include things like music therapy and massage therapy? And the answer is yes. So as I mentioned, many of these programs are housed under one umbrella. And so most community programs are typically set up as a hospice palliative care community support program. And so, yes, most of those organizations do have additional therapies. They may not all have a massage therapist, but certainly music therapy is a pretty common component of most hospice programs. Occasionally art therapy or pet therapy, but certainly depending on the size of the hospice organization, many do have the additional services such as, art or music or massage therapy available. It would be a question for specific hospice organizations, but I would say in general, most do offer therapies such as those. Thank you. Thank you so much, everyone. Have a great day.